Hey everybody, Mike here with you. Thanks for joining me today. I'm really glad you're here. Today we're going to talk about fentanyl in this presentation. Just a little bit of fine print before we get started. Remember, the content of this is derived from multiple sources and a lot of different texts. Anytime you're applying new information involving patient care, always follow your local state and agency protocols and guidelines. Use common sense and your best judgment. The material is presented based on my opinions and experience. So today we're going to talk about fentanyl, and let's get started. So the goals today are to get a basic understanding of fentanyl, the difference between fentanyl and morphine, the when, why, and how much of fentanyl use, and then some tips and nuggets. So what is fentanyl? It's a synthetic opiate analgesic. It's a pain reliever. We use it to treat pain. It acts as an agonist at the opiate receptor sites. And always remember that an agonist makes something work and an antagonist makes something stop working. Fentanyl is very hemodynamically stable because it's a synthetic opiate. It's not derived from natural sources like morphine is. So it's a very clean drug. It's highly lipophilic, absorbed easily through fatty tissue, and it has a synergistic effect when combined with Versed, which works great in some pretty specific circumstances. So fentanyl by the numbers. Your typical loading dose is going to be 25 to 50 mics. Some agencies, some protocols will have it as a weight-based. Really rapid onset, comes on really quickly. Usually in under a minute you should see some type of response from the fentanyl. Has a pretty short half-life though, usually about 10 minutes. 15 is really kind of pushing the half-life on fentanyl. You can give it a number of different ways, IV being probably your best, intraosseous, intramuscular, or you can also give fentanyl intranasally if you have a patient that's impossible to gain access and things like that. So you might do an interfacility transport where they have a fentanyl infusion running, and then depending on the literature and what source you've consulted, fentanyl is anywhere from 60 to 200 times more potent than morphine. So they're not really sure, so your mileage may vary. So it's available in a lot of different forms, different containers. The carpet jets, vials, ampules, and different amounts in each of those. Typically, it's going to be agency specific how much you carry. In our agency, we carry the 2 mil vials, and there's 50 mics per mil, so there's 100 mils in each 2 mil vial. So obviously that's going to give you 200 mics. Like I said, that's going to be kind of agency specific. So a quick look at the labels on fentanyl. Seems like a lot of gibberish, what is half of this stuff. Fentanyl citrate, obviously, it has the fentanyl in it, and the citrate is a carrier, derivative of citric acid. Tells you how much is in there, how much per mil. The NDC is the National Drug Catalog. If you type in the number, the 0409 number, online, it'll come up with the National Drug Catalog page for fentanyl. The C2, the C with the Roman numeral 2 in there, it's a class 2 controlled substance, or a schedule 2 for the DEA. And then the USP, USP is United States Pharmacopoeia. That's on any medication that we give. It's a agency that keeps track of medications and what they do and all that. So fentanyl versus morphine. Some of the difference with fentanyl, like we said before, really rapid onset, comes on really, really quickly. But it has a pretty short half-life. 10 minutes is probably the maximum you want to go between administrations. It's a very clean drug because it's synthesized, and it's really hemodynamically stable. Morphine, on the other hand, takes time to come on, minutes versus seconds for the fentanyl. Does have a really long half-life, though. It's going to last a little bit longer, sometimes up to 30 minutes. It's more of a dirty drug because it's derived from a natural source, so it does have some side effects, sometimes unwanted side effects. And hemodynamically unstable, it can have pretty profound effects on blood pressure sometimes. One other thing to keep in mind with fentanyl versus morphine, if you have a patient with renal problems, renal failure, dialysis patients, fentanyl is metabolized in the liver, so there are no toxic metabolites from that. You don't have to adjust the dose of fentanyl in those patients. Morphine, on the other hand, is metabolized in the kidneys, so you can accumulate toxic metabolites from that, and you have to adjust your dosing based on that, so keep that in mind. So, patient treatment. Of all that we do, there's really not a lot that we do. So, absolutely, first, do no harm. Treat the treatable and take away the pain. At the end of the day, those are the three things that we can do for our patients. So, take away the pain is a really, really easy thing to do. Sometimes it's splinting positioning. Sometimes it's narcotics administration. But it's one of the things that we can do. So, we should always try and do that one. So some of the indications, the when and the whys of pain management. So per protocols and again agency specific or region specific, indicated for burns, isolated extremity injuries, obvious fractures, hip fractures, and shoulder injuries should be considered extremity injuries. And then for all other painful conditions, you got to consult medical control for the fentanyl. That's due to change, but as the protocol is written right now, that's how it is, so keep that in mind. So the how much? Again, typical dose is 25 to 50 mics. Protocol says 0.5 up to 1 mic per kilo. If you call for an order, it's dictated by med control orders, so keep that in mind. And be a patient advocate. Oftentimes, it's hard for you to relay a clear picture of your patient when you're talking to the med control physician. So sometimes, my experience is they'll try to give you a lower dose or a lower amount than what you're looking for. So be a patient advocate and try to get an appropriate dose that's going to manage the pain, and always get follow-up doses and how often, and get that established before, while you still have med control on the line. Keep in mind, when you administer fentanyl, any drug really, with the exception of a couple, is push it slowly, 50 mics over maybe a minute, maybe a minute and a half. You don't want to slam dose fentanyl. So administration is really easy. 2468 principle. Anytime I do procedures, when I learn a procedure, then I'll try to refine it and make it as simple as I can. Less moving parts. Try to eliminate a lot of that math and things like that. There's more than one way to do this. Everybody's going to have their own way. The way I do it, what works for me, is I'll take a 10 mil saline flush, and I'll push out 4, and that's going to give you 6 mils in the flush. And then I'll pull the 2 mils of fentanyl, the 50 mics and 2 milliliters, into that flush, and that's going to give you 8 milliliters of liquid. So the easiest way to break that down is now every 2 mils is going to be 25 mics, as demonstrated in the picture. So you're going to have 100 mics over 8. So if you need 25 mics, if you need 50 mics, it breaks down the math a little bit easier. and then you just push. And remember, push it slowly. So let's talk about a quick case where fentanyl is really appropriate, and maybe a little better than morphine. So think about this guy. What do we got going on with this 12 lead? Got some elevations. Looks like in 2-3 in AVF. And then we've got our reciprocal changes, V1, V2, V3, right, with the depression. So what would you guys call this? I'm thinking probably an inferior MI. So the vessel involved would be the right coronary artery, the RCA. You would probably want to do a V4R, maybe a right-sided 12 lead, or even a posterior 12 lead, to see how much of that right ventricle is involved with the inferior MIs. So let's think about that 12 lead for a second. It's going to be preload dependent because it's the right ventricle. The right ventricle supplies the preload to the left ventricle. So if we somehow change how much preload's coming out, we're going to change how much the left ventricle can pump. So with morphine, remember morphine's going to be a vasodilator. It's going to take a 6-gallon tank and make it into an 8-gallon tank with only 6 gallons in it. So your preload is going to drop. Again, that's going to drop your cardiac output. Nitroglycerin, the same thing. It's going to make the tank bigger. So fentanyl is really good in that it's not going to increase the size of the tank, but you're going to manage the pain, which brings us to this. So your sympathetic response to pain, everything goes up, right? The fight or flight thing, increased heart rate, increased blood pressure, your respiratory rate goes up, increased cardiac oxygen demand. And with an MI, all those are bad things because you're taking a sick heart and you're making it work a lot harder. So if you take away the pain, you could expect a parasympathetic response. Not really parasympathetic response, but you're going to kind of blunt that sympathetic response a little bit. It's going to help with the heart rate, and that in turn is going to help with that increased cardiac oxygen demand. It's going to help kind of lower that a little bit. It's going to help with the blood pressure, and it's going to help with the anxiety and the respiratory rate. Those are all good things when you're treating cardiac patients. So some other tips and nuggets. What if I give too much? Simple fix, Narcan. A couple of things to keep in mind though are this isn't like a heroin overdose where you want to just kind of titrate your Narcan administration to support respiratory rate. You can give all the Narcan all at once. You're not going to put them into withdrawals. But what you will do is now you've occupied all those pain receptor points, so further fentanyl administration isn't going to work as well until the Narcan is burned through its half-life. So keep that in mind. If you overdose them, and you can give a little bit of Narcan just to kind of get the respiratory rate up and kind of support them through that until the fentanyl burns off, or you can give all the Narcan, but then you're not going to be able to treat the pain. So keep that in mind. Sometimes you may have seen this little symbol here. That's just a symbol for micrograms. Sometimes they use that for shorthand on written orders and things like that. So some other tips and nuggets. If you have a patient that's altered at home or in a like a extended care setting or skilled nursing, they're altered, you really can't figure out why. They really don't fit the framework of like hardcore drug user or heroin overdose or whatever, and you really can't figure out what's going on. Read through their med list. Some of the things you might notice are sublimase, which has been DC'd in the U.S., but sometimes people hang on to their scripts for a couple of years and then they'll just use them for whatever. Actique, which is the lollipop form of fentanyl. You have some Duragesics, which are the the patches, and Abstral, which is a sublingual administration. A lot of the hospice care, the cancer patients are going home with scripts for fentanyl, and so some of these might show up. Keep that in mind. Also, remember, with an altered mental status patient, look for a narcotic patch somewhere, on their back, on their chest, on their abdomen, on their inner thigh. There are actually forums online where people are, discussing where best to place fentanyl patches. So have a high index of suspicion, and always, always, always look for that patch. If you like this presentation, or if you have questions, if you have comments, if you have ideas for other shows we could do, or just some feedback or whatever, you can reach out to me at themedic0project@gmail.com. If you think you got some value out of this presentation, tell your friends, help spread the word. Please subscribe to the YouTube channel. Really, really thank you for watching. Appreciate all the support. Hope you got something out of this video. So our goal is to improve 1% every week with the Medic Zero Project. This is Mike. I am Medic Zero. Out.